This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2014, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Oxygen Therapy in the Home, Going Beyond the Four Walls. Upon completion of this AARC webcast, participants will be able to understand how the oxygen therapy differs in the home versus the acute care setting, identify challenges in the delivery of long-term oxygen therapy from the technical aspect as well as the reimbursement, discuss the importance of accurate oxygen titration during activities of daily living and why it is essential to match devices to individual lifestyles, and identify resources that are available to help patients understand oxygen therapy in the home. I am pleased to welcome Ms. Kimberly Wiles. Kim is a registered respiratory therapist, certified pulmonary function technologist, and Vice President of Respiratory Services at Kling & Smith Healthcare in Pennsylvania. Kim is also the AARC Home Care Section Chair. Neither Kim nor I have conflicts of interest related to this presentation. Any use of images or brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis. Kim, welcome to the program.
Thank you, Shauna. I hope everybody can hear me okay. The first question I want to pose to the audience is how many in the audience actually work or have worked in home care? If you could press the button or the green arrow if yes, and the X if no, just to give me an idea of the audience that I'm addressing. Okay, well, it looks like we have a lot of people in both, so that's good. I want to get the point across of how differences occur within long-term oxygen therapy in the acute care setting as well as the home care setting.
Kim, I think we lost your sound there. Can you click your talk button again?
Can you hear me now?
I can, thank you.
Okay, sorry about that. I don't know what happened. Okay, so when we talk about long-term oxygen therapy outside the four walls of a hospital, it does create many challenges. Whenever we're in the hospital, we are in a very controlled environment, and the patient really doesn't have any choice but to follow what we tell them to do. So that's what some of the first things that creates our first challenge really is non-compliance in oxygen therapy. And this is something that we have to deal with really on a daily basis with patients, because once they get home, they start to feel a little bit better and they really don't think that they require the oxygen therapy anymore. So that's our first thing we deal with. And there's varying reasons, but you know, I quote Bart Shelley from the ATS conference in 2009, is would you use a drug, and we all know that oxygen is considered a drug, would you use a drug that prolongs life, doesn't hurt, is well tolerated, costs very little, improves exercise, mental function, heart function, respiratory function? So why do we have such an issue with patients and compliance? Well, vanity. One of the first things we hear from patients when they get into the home is, I don't want to wear that in my nose. It appears to everyone that I am sick. And it gives an impression to the patient that they're telling their story by letting everybody know that they're sick and they have a problem. So they don't want to wear it. There's different manufacturers out there that have tried to make devices that are a little bit more concealable, and I'm sure if anyone has seen the glasses that actually incorporate the nasal cannula into the glasses, you know, people do try those type of things, but vanity is a very, very important to a lot of patients. And I know within our home care company, and I'm sure those of you out there that have been in home care, we've actually had patients tell us that when we deliver the oxygen, please park down the block so nobody actually sees you coming in, because they don't want to let people know that they're sick. The other reason is loss of independence. There are a lot of portable devices that are being manufactured now that does give patients a little bit more independence, but in their mind, they're tied to 4 or 7 feet of tubing and a device that they actually have to carry around or pull around on wheels. So this is a very, and it's really hard for patients to, you know, we say it's a drug, you need to take it, this is why, but in their mind that it's not a pill and I'm tied down. Expense is another thing that's coming into play as we move into more areas of reimbursement where insurances are requiring copays and higher deductibles. And in the past, some of the private payers didn't require copays on oxygen therapy, but recently have implemented that. I know we've experienced here in the Pittsburgh area, and we've actually had patients pull up to our warehouse with all of their oxygen in the car and say, take it, I can't afford to pay it. Even though it may only be $15 to $20 a month, that is a lot of money for somebody who is on an income that is very limited. So if it's between the oxygen or a blood pressure medication or whatever it may be, they choose to go with the medication. The other thing is there's no perception of decreased shortness of breath. So if a patient doesn't feel any better, in their mind, why am I wearing this? I don't feel any better, but I got to carry around a 5-pound unit, a 10-pound oxygen device. I'm tied to tubing, and it doesn't make me feel any better. So that is another roadblock that we have, is the lack of perception. There's just no perception of shortness of breath. And the weight. You know, every day, if I ask a patient, what would you like to see in home oxygen therapy, they would tell me they would like a device that weighs 1 pound and will last for a week. Unfortunately, as we learn, as we go through this slide presentation, you'll see that not all devices are created equal, and the smaller is not always the best unit to choose for somebody. But that's what patients want to see. And they also believe it limits their lifestyle. And again, you'll see as we go through this presentation that there's been a lot of oxygen therapy equipment that has been developed to improve patients' lifestyle. When I first started into home care many, many years ago, the only options patients really had was an e-cylinder dragging it around on a cart. Well, as we go through this presentation, we'll see that things have really is moving forward in the future to allow patients to be consistent with the lifestyle that they were once used to. So we all know as respiratory therapists, if we have untreated hypoxemia, it can lead to multiple complications. And this is just a few things that we know. Cardiac, we can have cardiac complications, cognitive decline, pulmonary hypertension, acute respiratory failure. So we want to make sure patients are oxygenated at all levels of care. So this is a slide by Patrick Doon that was published in Respiratory Care in August of 2009 that showed that we really need to make sure we're oxygenating our patients through the whole continuum of care. So a lot of times what happens is patients are in the hospital, they're checked, their saturation is checked to see if they qualify for oxygen. And once we get our qualifying testing out of the hospital facility, then we really stop there. But in essence, it's really important once they get into the home that we understand what they need during activity, what they need during sleep, and also what do they need at higher altitudes. And, you know, patients really don't understand the impact high altitudes have on them when flying, and that's something that patients really do need to understand, especially with the development of a lot of the portable concentrators coming into play, and we will talk about that a little bit later as well. So we want to make sure that we are oxygenating patients throughout the continuum of care. This was a landmark study, and everybody, I'm sure, has heard of the KNOT study, which was done many, many years ago. It was revisited back in 2000. But what it basically showed was that with increasing ambulation and oxygen support, patients actually lived longer. As you can see here, if you can see my pointer there, they actually lived longer and participated in the study longer. So we want to make sure, if we want to improve survival, we want to have a compliant patient while ambulating and making sure that their oxygen levels are maintained. And, you know, we all hate this animal or this beast, but, you know, working through reimbursement policies has probably been the second biggest challenge next to compliance with our patients. Unfortunately, reimbursement has taken a very wide turn in the road, and a lot of things are being looked at now that really weren't being looked at as closely in the past. But as far as reimbursement goes, I'm specifically right now speaking of Medicare. And I don't know about what areas everybody is in, but most of the time private payers will follow Medicare guidelines as well. Maybe not as strict, but they do follow a form of them. So home oxygen therapy is covered when a patient has a pulmonary diagnosis, if an ABG or pulse oximetry is performed by a qualified provider and a DME company or a durable medical equipment company is not considered a qualified provider, testing done within 2 days prior to discharge and in a chronic stable state. And this next bullet point is something that they've really increased awareness of and auditing purposes for the DME companies. But we also have to have documentation of other therapies that have been tried prior to oxygen therapy. So a lot of times we can find that information within a medication profile, because if the patient has COPD and they're also ordered albuterol treatments, then we know that albuterol or some form of pulmonary medicine has been prescribed. So that is something that was also tried prior to the oxygen therapy initiation. We look at progress notes. We look at history and physical of things that have been tried in the past, and also any kind of testing, spirometry, chest x-ray, if they were ventilated in the ICU, and non-invasive ventilation at some point within the hospital. So we look at all that. So for those of you that are in the acute care setting and are doing a lot of testing for patients before they go home, that's one of the things you want to keep in mind, that more than likely the home care company is going to ask for a lot of that information. And in the past, all we needed was the saturation, but now we need a lot of supporting documentation to support that. So what is a qualifying test? Well, an ABG or a pulse oximetry both qualify patients, but if they're both performed on the same day, then the ABG value has to be used. We have acceptable pulse oximetry methods, rest and awake. So if the patient qualifies at rest, and we'll talk about the qualifying tests here in a minute, if they qualify at rest, then they are entitled to oxygen equipment 24 hours a day, which would include a portable unit. If they don't qualify with their saturation level at rest, then we can go into an exercise study. This is a 6-minute walk that requires a series of 3 tests done during a single testing session. So the patient needs to be at rest, off oxygen, and have to show a non-qualifying result. So a qualifying result is if they are less than or equal to 88%. If they are at rest, then they have to show a saturation greater than or equal to 88%. If they are exercising, then they have to be on room air, and they have to show while exercising that they have a decline in their saturation below or equal to 88%. Once they're exercising, then oxygen must be placed at intervals, so 1 liter per minute exercise, and you have to show improvement in the test results while they're exercising. So very important to have those 3 steps. And also sleep. Patients can qualify at sleep. If they don't qualify at rest or with exercise, then they would qualify at sleep, but at sleep they would not be allowed to have a portable device. So I'm just going to go through these real quickly, but qualifying test results fall into 3 categories. Group 1, which is a 12-month coverage. The PaO2 has to be less than or equal to 55 millimeters of mercury, or an SpO2 less than or equal to 88% at rest. The same test results for 5 minutes during sleep would qualify a patient for sleep only. You can also have a decrease in PaO2 greater than 10 millimeters of mercury during sleep. And if they don't meet qualifications at rest and they don't meet qualifications nocturnally, and they only meet qualifications during exercise, then we only get to give the patient a portable device, which seems a little odd because in some scenarios you need the stationary device for the portable device, but unfortunately they will only pay for a portable device at that time. And then the patient has to see the doctor within 90 days. Then you have group 2 coverage, which is these in-betweeners. They're covered for 3 months. So these are patients that would have a PaO2 between 56 and 59 or an SpO2 of 89% at any of those levels. And a diagnosis of congestive heart failure, pulmonary hypertension, erythrocythemia are a couple examples there. And then of course group 3, is the non-covered patients. So we are faced with a lot of reimbursement challenges in the durable medical equipment world and the home care side, and the number 1 challenge we have is competitive bidding. And unfortunately, because competitive bidding has decreased the reimbursement to a very, very low level, it does not allow for any kind of extra services. For example, whenever I started in home care many years ago, we got paid a lot of money a month for oxygen. So it behooved us not to add a respiratory therapist into the mix and send a respiratory therapist out on a regular basis to follow that patient on a monthly basis. Reimbursement dropped, and then a lot of companies went to, well, we'll send a therapist out every 3 months to take a look at the patient and to see how they're doing and if there's been any changes to that patient. Then reimbursement dropped again, and it went to, well, we'll send a therapist out once a year and take a look at the prescription and if the device is still meeting their needs. And with competitive bidding, unfortunately, that took us down to a level where they're barely paying for the equipment that is provided in the home, so a lot of those extra services are not available. With the competitive bidding, there are limited suppliers doing full line of oxygen modalities, even though whenever you bid in the competitive bid area that you will supply all modalities of oxygen. We have suppliers in many of the regions that just don't do it, which limits patients' availability to some of the higher end products. So that means limited equipment modalities by provider as well. We also have a 36-month cap that came into play, and again, I'm not going to get into a lot of these in detail. This could be a whole lecture in itself, but a 36-month cap means you supply the patient for 36 months, you get paid monthly for 36 months, and between 36 months and 60 months, you don't get paid anything, you just need to service that patient regardless. The only thing that you would be able to bill in those 2 months is if the patient needed supplies, or refills on portable oxygen contents, such as gas cylinders or liquid oxygen. There's also a thing now that requires a written order prior to delivery, which is causing a lot of angst within the acute care setting because sometimes physicians will just write it in their notes and don't always give you exactly what you need. But written order prior to delivery is required with NPI numbers and a lot of other information. We have copays and higher deductibles on patients and the infamous audits, which is why we're asking so much information of the acute care facilities to be provided, because we are faced with audits that are prepay audits, which means we don't get paid until we provide the necessary documentation, or After the fact, if we don't provide it within a certain amount of time, they will recoup their money. So there's a lot of challenges in reimbursement that didn't exist up until about 3 years ago. So now when we really talk, let's put reimbursement off to the side because that's an ugly animal, but let's go back to the patient. It's all about the patient. So how do we transition that patient from the hospital to the home? And what is the difference between the oxygen systems in the hospital and in the home? Within the hospital, number one, we don't have any problem with compliance typically because we put the cannula on their face, they wear it, when they're ready to go home, we take it off or we send them home with it. That's where we have a challenge with compliance and following their prescription. In the hospital, you're in a controlled environment. In the home, you're in a very uncontrolled environment. So uncontrolled that in many cases, in some of the rural areas, there isn't electricity. There are still dirt floors out there, believe it or not, and there are homeless people that do require oxygen at time, and how do you provide that? That's a challenge. In the hospital, it's ordered in liters per minute. In the home, we're in milliliters versus liters per minute. Now, we do have continuous flow, liters per minute in the home, but the majority of our portable systems are in milliliters. In the hospital, we have an unending supply. We know we all have a big bulk tank in the back that supplies us with liquid oxygen, and in the home, we have a very limited supply. In the hospital, there are limited options. You have wall oxygen versus cylinders, and in the home, there's multiple devices to choose from. In the hospital, it's 100% gas source. In the home, we're at about 90 to 95% gas source. And with the cylinders, though, we do get up around 99% pure as well, but we still have, in some of our devices that we'll go through, the gas source is not 99.9% pure oxygen. In the hospital, we test at rest or 6-minute walk or potentially nocturnal, which I left out there. In the home, we're testing during ADL activity, or we should be, because that's when the patients will exhibit signs of hypoxemia or decreased saturations when they're moving around their home, because maybe now it has created challenges for them. So it's important to work through their activities of daily living and go through and monitor their saturations. So when we talk about conserving devices in the home and intermittent flow devices, what these things is they're used as a regulator for cylinders, and they're also built into other oxygen systems in order to conserve oxygen. You know, conserve the word. We want to conserve oxygen so that the portable devices will last longer and they can be outside the home longer. Very important, but we want to be careful we don't conserve too much oxygen and the patient isn't being provided with an adequate amount. So these are used majority of the time with portable oxygen. They're what we call intermittent flow or pulse delivery instead of continuous. So they will deliver a bolus or a volume of oxygen at the beginning of inspiration, and it will end somewhere during the inspiratory phase of the cycle, and every pulse mode delivery or intermittent flow delivery device is not created the same, and that's another challenge that we face in home care. We look at oxygen being delivered at various phases of the inspiratory cycle. We know volume is being delivered at various flow rates. We don't know what those flow rates are a lot of times. It requires an interface that will sense the breath, so we must have a device that has a good sensitivity level in it. The settings on the dial are only a guide. It's a 2 is not a 2. So when you order oxygen for a patient coming out of the hospital, you may order 2 liters per minute. But when they get to the home, we can give them 2 liters per minute, but when we put them on their portable device, they will not be getting 2 liters per minute. They will get a set volume at whatever setting we land at in the home. The 2 is usually a guide for us. And then at that point, we go the next step and have to get additional prescriptions from the physician. But the settings on the dial are only a guide. Few clinicians really understand that because pulse delivery has so many capabilities and limitations, and a lot of physicians really don't understand what they're ordering as well. And I will go through a personal story when we get to our portable concentrators. So if you look at the basic oxygen delivery fundamentals, we really want to deliver oxygen during the phase where we consider it useful oxygen. Okay, so this takes us back to our respiratory education school days. We want to deliver oxygen during the first 70% phase of the breath because that is the best time for gas exchange to occur. We don't want to deliver it during the dead space phase, nor do we want to deliver it during exhalation phase, because that is when oxygen is wasted. So we want to make sure we're delivering oxygen when the patient breathes in during the first 70% phase of that breath. When we talk about pulse flow and conserving devices, modes of delivery, there are 3 different types. We have what we call the fixed bolus volume. There's a predetermined bolus size that's calculated at each setting on the dial, and every conserving device has a different predetermined bolus size at each setting. There lies in the problem. With this type of mode of delivery, if you have increased respiratory rates, it may exceed the preset maximum breath rates that are established by the manufacturer. And what I mean by that is there are no guidelines or FDA guidelines out there that requires certain amount to be delivered at each setting and how many at a certain predetermined breath rate. So what that means is if I'm a manufacturer and I go to I want to submit to the FDA that I would like to I'm creating a conserving device, and I will guarantee that it will deliver X amount at each setting at a maximum breath rate of 20. And a lot of the devices are maximum breath rate of 20 or 24. Typically, you do see some up in the higher 30s and the higher, like 30, 35. But typically, most of the conserving devices out there are created where they only guarantee their oxygen delivery up to a breath rate of 20 or 24. Again, some are a little bit higher, but the majority of them are at 20 or 24, which takes us to another problem because most of our patients in the home, if they have COPD, pulmonary fibrosis, any of the lung diseases that we're dealing with, a lot of times their breath rate is already above that point, and when they start to exercise and their breath rate goes up, then that fixed bolus actually goes down. So the patient's oxygen demand is actually less. Their demand is more, but the delivery that it's providing is less. Another mode of delivery is minute volume. And what this is there's a set volume over a minute, and that delivery really depends on the breath rate. So if you have a patient that has a higher breath rate, then they're going to get less volume delivered. If you have somebody who has a very low breath rate, you'll get a higher volume delivered to them. And then the third type is an adjustable. This is an auto-titrating based on breath rates. There's one new one out there that is actually auto-titrating based on movement, but there is another one that's actually based on breath rates. As breath rate increases, the bolus delivery actually increases instead of dropping off. So what happens is when the patient puts this device on, it figures out what the patient's baseline respiratory rate is, and if their breath rate goes 4 above that baseline, it'll automatically kick in, increase the flow, and also increase the bolus size. If it increases another 4 above that, so 8 above their baseline, it'll actually increase the volume a little bit more and the speed a little bit faster. So this actually auto-adjusts to their changing breath rates. So those are the 3 different types. You also have types as far as mechanical and electronic. So any one of the 3 that I just talked about can be either mechanical or electronic. Mechanical meaning it's driven by gas, pneumatic. Pneumatic conservers are strictly mechanical and are powered by gas in lieu of batteries. And they typically require a special dual lumen cannula, 1 port for sensing and 1 port for delivery. And then you have the electronic, which operates on a battery and uses electronic circuitry to measure and deliver a dose of oxygen. These use a single lumen cannula typically. With the electronic devices, these are typically more sensitive to the patient's needs. Unfortunately, patients don't like to be bothered by batteries, so sometimes this becomes a deterrent for their using it. So this is a quote from McCoy and Adams in a bench study comparison where these devices all have varying performance characteristics, which include bolus, volume, trigger sensitivity, and trigger response time. These differences may be relevant, and therefore clinicians should be familiar with the device specifications. So as we go through here, you'll see how products do vary, and all we have to remember is not one device matches every patient. So we have to make sure when we get that patient in the home that that device works for them. So I can't say one device is better than another. I have my preferences, but we have to make sure they're okay on the patient, and that's where our expertise comes in. So when we talk about options for home oxygen devices, they're endless, and this is just a picture of a few. And every day we keep coming up with more. And if you go out and do a Google search and put in conserving devices, unfortunately things come up that best savings, longest conserving device, things that really don't put the patient in the middle. They're worrying about how much oxygen we're conserving so that that patient will have more outside the home, which is good, but not if we're not saturating that patient. So you've got to be very careful and understand your devices. So I'll go through these a little quickly, but oxygen concentrators are the foundation of home oxygen therapy. And if we look at a stationary oxygen concentrator, they do run by electricity and they make their own oxygen. The downside of it is there is a little bit of a cost to the patients because they do run by electricity. Some of the newer models, that electricity requirement is a little bit less than it used to, but typically you could see a electric bill going up around $15 to $20 a month, and that is if they run it 24 hours a day. So, you know, that does seem like a lot, but if they're only using it, you know, during sleep and maybe using their portable during the day, then they may not run into that much. It may only be $10. But, you know, don't let a patient tell you that their electric bill went up $100 a month and that's why they're turning it in. We've heard that. There's something else that's causing the electricity to go up. These stationary concentrators are only continuous flow devices, and they're not portable, as you can see. They usually weigh anywhere from 30 to 45 pounds. Some of the newer units coming out are a little bit lighter, but they're still heavy. They are on wheels, and most of the time patients have a cannula, or a tubing and a cannula attached to this device, and maximum tubing is usually 50 feet, which sometimes you've got to be careful of because patients tend to want to put 50 feet on top of 50 feet, and then you're compromising the flow at the end of the line. So there are things that you do have to worry about on these. They are 85 to 95% pure oxygen. And it depends if the patient hasn't had it serviced or the filters are dirty, that purity could go down. And the flow range on these devices are 1 to 10 liters per minute. So unfortunately, if you get a patient above 10 liters, you have difficulty servicing that patient because the manufacturers don't recommend wiring the concentrators together because of a back pressure that it places on the unit. So then we have to go to, there is one manufacturer, I think it's Aircept, that you can wire their devices together, but the other manufacturers, as far as I'm aware, you cannot. So they're noisy. Newer units are a little bit quieter. There is low maintenance cost for the durable medical equipment provider. They put these in and typically don't have to go back and see the patient for a year because manufacturers' recommendations only require yearly checks on these units. One thing I didn't mention here, and I meant to put in my slide, is on these units you can have a built-in oxygen concentrator alarm system. So basically what that means is it's constantly analyzing the percentage of oxygen that the device is putting out. Unfortunately, this is not a requirement for home medical equipment companies, but it is a nice safety feature for patients because if you're not going out to the home for a year, how do we know this is delivering 85 to 95% pure oxygen? So these devices will have a they call an oxygen concentrator indicator, which basically is just an oxygen analyzer that we're all familiar with, and it will give us an alarm system where if the oxygen is being put out in the specified range that the manufacturer recommends as therapeutic, it will register a green light. If there is something wrong and the purity is dropping, it will show a yellow light. And if it is below therapeutic standards, which is a lot of the times 85%, then it will alarm and shut down. So those are safety features that stationary concentrators really should possess so that we know what the purity level is being put out. We have non-delivery system concentrator filling portables. So this really has exploded over the past probably 5 years because of the the decreasing reimbursement over the past several months. What has happened is the durable medical equipment companies have to find a way to keep oxygen in the home without making multiple deliveries because reimbursement is not high enough to even start a truck up a lot of times to go out and deliver gas cylinders or liquid oxygen. Not to mention, this is a nice feature because patients become very independent. What happens is the patient has their stationary concentrator that looks like this. These are just different models. And then they have the capability of filling a portable cylinder on the device. Most of them will fill Cs, M6s, ML6s. Respironics does make one that will fill an E-cylinder. So right here it is, I'm sorry. So there are different manufacturers popping up with a lot of nice features of these, but the problem is still fill times. So in order to fill this small portable, it may take 2 hours. And if the patient doesn't understand their schedule and know when they need to have a portable filled, they may not have a portable unit to go outside the home when they need it. Use times are lower. Oxygen purity could be a little bit lower, depending. Most of these have a built-in oxygen concentrator indicator as well that will actually not fill this portable if the percentage is below therapeutic. So we also have devices on here that we have to put the conserving devices, the oxygen conserving device, because if not, an M6 cylinder at a setting of 2 will last the patient very limited time, but if you put them on a conserving device, you'll get a little bit more time out of that. Electricity is another issue with these because now in some cases, this is an example here, you actually have 2 devices you have to plug into the wall. That adds electricity. And they're noisy. So a lot of times these, we tell patients to put them in another room of the house that they're not sleeping in, and then string their oxygen tubing to the room. But it can be a challenge because of the noise. And we all know what compressed gas cylinders look like. We know they're 99% pure. The size and weight varies. The pressure range will go 2,200 to 3,000 psi. 3,000 psi is great in the home because you can increase the time the patient is outside of the home. The problem is this type of cylinder is a little bit more expensive. The delivery and storage can be an issue. We took over a VA contract several years ago from another company that was out of state. And whenever we went into some of the veterans' home, they had stockpiled, in excess of 100 cylinders in their home, which is a severe safety issue. Imagine a home with 100 of these units in the home not stabilized. So this can be an issue. Safety. A lot of times patients don't understand that these patients can't be just standing free-willy in their living room. And, we all know if they knock over and they knock the top of this off, the head of the cylinder, then we can run into a lot of issues down the road, obviously. And we always put a conserving device or try to put a conserving device to extend the life of these cylinders. Liquid oxygen, unfortunately, is probably the Cadillac of oxygen therapy, but unfortunately has really lost momentum in the home care world because, unfortunately, it's a very expensive form of oxygen therapy to be delivered. Another thing you have to consider with liquid oxygen, the patient would have this in their home, which is a large base system, and they would have a portable device that they would fill off of that stationary unit. The problem is if these units are placed in a very warm situation, then the temperature will cause evaporation. So this is a very cold gas. Cold liquid. It's chilled to a minus 300 degrees Celsius, and as it goes through the coils within this, it becomes a gas. So as this warms in a room, and we know sometimes patients that live in the West, I know not in Pennsylvania because we're a little cold here, but in the West where there's very high temperatures, and if there's no air conditioning available to them, this will evaporate rather quickly. It does have high flow capability, so if you have patients that are in excess of 10, this would be a mode of therapy that you could do in the home. Very expensive though. The purity is 99.9%. You know, safety can be an issue because it is a cold gas, minus 300 degrees, so if the patient would come in contact with it, we could cause a lot of burns. And again, expensive. I hate to quit bringing this back into the picture, but unfortunately it's a reality. The cost to deliver liquid oxygen exceeds the reimbursement that we receive during that 36 to 60 month period. So most home care companies across the country have really eliminated this as an option for patients, you know, which is a real travesty because a lot of patients, this is the best method of choice for patients. And we're seeing it all over the place where liquid oxygen is just going away, unfortunately. What's nice about liquid oxygen portables is you can get devices that have continuous flow or pulse. They're lightweight, and they last longer than gas cylinders. So in these particular cases, you have a portable, let's say, for example, let me see, I know this one. This one weighs 3.6 pounds. This one weighs 3.4 pounds. This one says you can get up to 10 hours at a setting of 2. This one will give you up to 5 hours at a setting of 2. So you can see they look alike. One delivers a lot more oxygen, or I'm sorry, one can hold the same amount of oxygen but will last a lot longer. So that tells me one might not be delivering as much as the other one is. So those are some of the things that we take into effect when we're monitoring and working with patients in the home. Portable concentrators, this is where we've had an explosion, and you know, we got to take a lot of things into consideration with portable concentrators, and that is they can only make so much oxygen. There is a maximum production that they can produce. We got to look at what is the dose per setting that they're delivering. What is the purity? These don't have built-in oxygen concentration indicators like the stationary portables do. What is the battery life, and what is the expense to the patient for extra batteries? Because a battery can cost a patient in excess of $300. What is the weight of these units? What is the sensitivity? And most of these are approved for airline travel, which is great, but we got to make sure we match the right device to the patient. So when we look at these concentrators, this portable concentrator has about 2,000 mLs available per minute for delivery, where this one has about 800, and don't quote me, that's not exact, but this one is definitely a higher production level, but we got to remember this one weighs 10 pounds and this one weighs 5 pounds. So, you know, we got to take into account what best fits that patient's needs. So, you know, some of the challenges that we've talked about in providing oxygen is there's really no FDA standard for dose setting, and that creates dramatic variation in the device's capabilities. You know, we have to titrate patients on their home ambulatory system. And what this graph is showing, this was a study done by Bob McCoy with Valley Inspired Products, where he looked at multiple conservers here, and he put them all at a setting of 2. So they were all at the same setting on the conserving device, but as you can see, every one of them delivered something different at a setting of 2. That doesn't mean this one won't work for a patient and only this one will. It means we have to match the device to the patient. He also looked at varying respiratory rates. As we talked about earlier, as the patient's breath rate increases, a lot of these devices can't keep up with their increasing breath rates. So this is one where he took 4 systems and he put it at a setting of 2, and they were done at rest and exercise. So at rest, they were at 15 breaths per minute, and you can see the varying breath rates at a setting of 2. And then they increased the breath rates to 30 with exercise, and you can see how they all actually dropped off in the amount of oxygen that was delivered on inspiration, with the exception of this one, which is that auto-titrating device that I had mentioned earlier. This was just a study that was done out of San Diego, Trina Lindbergh et al. It was in a pulmonary rehab setting. And what they did is they took 65 patients after they were discharged from the hospital. They brought them back into their pulmonary rehab facility, and they put them on a treadmill on their device that they're using at home. And the goal was to meet 90% saturation on the treadmill while exercising. Of those 65 patients, 60% of them did not meet the target of 90%. 20% of them needed readjusted upward, and 40% of those devices could not be titrated at any setting, and the device needed replaced. So that is a little inkling of what we're dealing with in the home. This is a device out there called a clinical oxygen dose recorder, or coder. It's not used a whole lot out there. I think it's one of these best kept secrets. Unfortunately, there is a cost associated with these. But what they do is you can actually connect any oxygen system into this device. And if you can see it on the gentleman's hip here, you actually take oxygen from the portable device, put it into the system, and then from this point out goes to the nasal cannula and onto the patient. So what we can do with this coder is it actually enables the RT to determine the adequate conserver from inadequate conservers. So what I do with this personally is if I have a new conserving device, I will actually put that conserving device on an oxygen cylinder, run it through the coder, and I can actually get a printout of what's being delivered at varying breath rates, and I'll show you that a little bit further here. But we also can demonstrate saturation improvement and allows for monitoring patients while enforcing breathing skill sets. So you can actually look at breath rate, pulse oximetry, saturation, IE ratio, spontaneous breath rate, trigger pressure, flow rate. So there's a lot of information you can get from this, and I've seen these used in pulmonary rehabs, which is ideal, and there are very few companies across the country that actually use these in the home, but it is a nice little device. So patient data, you can get saturation, you can get heart rate, you can get breath rate, and IE ratio. Equipment data, you can get bolus size, sensitivity, and pulse flow. Those are the three key items you can get from the equipment data. So this is an example of what the report would come back with. It's wireless on your computer. So there's a program that will allow you to look at patient data. If you look down here at the very bottom of this graph, that is the patient breathing in and out. The graph on the top is the actual oxygen bolus that's being delivered. This area right here gives you oxygen dose data, and this orange area on the top gives you patient data. So there's a lot of information that you can get, and you can get trending graphs and a lot of different things while exercising. But this is an example of what I do whenever I get a new conserving device, is I put it on my coder. And this was a mechanical conserver that we looked at. And what it is showing here, if you look on the bottom graph, patient breathing in and out, top graph, that's the bolus being delivered. At a setting of 2, this mechanical conserver was delivering about 29 cc's per breath, inspiratory breath, but at a very quick flow rate. So the oxygen being delivered is not being delivered during that full 70% phase of the inspiratory cycle like I had mentioned earlier. It's only being delivered at the very beginning of that breath. So there's still a lot of room for oxygenation to occur. Now if you look at that same device with an increased breath rate, so we increased our breath rate over here. Now we're looking at a pulse volume of 10.2 versus the 29. So you can see as that patient started moving around and exercising, that when they need the oxygen the most really dropped off. So that is what we would call the fixed bolus delivery method. This is one of the electronic conservers, and this is the auto-titrating one that I mentioned about earlier. It's called Smart Dose. And what it does is it's the one that auto-titrates based on breath rate. So here is an example of one where the pulse volume here on the top is 29.2. And if you look down here at the bottom, this is the blue graph, they're breathing in and out. Top graph, this is the mode of flow delivery. It's more of a square wave pattern. So more of the dose is delivered during the first 70% phase of the breath. And we look up here at the spontaneous breath rate. We're at about 13 to 14. Now, if I increase my breath rate, my pulse volume is actually 66 when our breath rate went up to 20 or 24. So this just gives us a good idea of what we're delivering and when, and how conserving devices respond to patients' breath rates. So very important when we're titrating patients in the home, and that's why it is so important to match the device to the patient at all activity levels. So why do we care about oxygen delivery and ambulation? Well, we know active patients stay healthier. We know activity from the NOT study increases survival. We know activity promotes better quality of life. And we know that healthier patients decrease utilization of higher healthcare costs and resources. So we want to make sure these patients are saturated. Traveling with oxygen, we'll go through this briefly, but trains, planes, automobiles, and boats. We can travel with oxygen. It is an option. What we need to explore with each travel method is what are their regulations, and we need to investigate that. So we recommend that the patient contact the company providing travel. This website that I included here gives some tips for patients that are traveling. They need to understand altitudes and prescription variability. What we got to keep in mind, too, is there really isn't any reimbursement by insurance companies for travel. And many years ago, when reimbursement was much better than that, a lot of DME companies actually arranged for travel for patients across the country. And, I know within our company, it took almost one full FTE to arrange for patients in travel. Unfortunately, you can't provide that service any longer whenever the reimbursement levels are so low. Again, that was another added benefit patients were able to get. But fortunately, there's been a lot of companies that pop up out there that this is what they do for patients. This is their business. So I know what happens to a lot of DME companies will actually provide travel equipment at no charge or deposit, such as the portable concentrators, so that they can travel without an added expense or burden. Again, some companies will make arrangements, some don't. And these last four bullet points are actually specific companies that do provide travel service only. And if you do a Google search, you can actually find these, many more than this out there. I know there's specific ones for Las Vegas. There's ones, the second one here is called CPFT. It's actually a group of respiratory therapists that arrange for travel for patients via boat, and they provide cruises every now and then. So it's a nice option for these patients. The last one there is actually a business that this is what they do, is they arrange for travel for patients and provide equipment at the drop of a hat, really, for patients. So, with this all said, and everything sounds good as far as what we need to do in home, but there are still existing problems with home oxygen. Payers don't pay for what the patients need. So they're not paying for any kind of service. They're paying for a product. They're paying for a piece of equipment, and they're not paying for the services that are required to keep that patient at home. And patients don't want to pay either. Unfortunately, one of the things I should have added with compliance is I did with copays, but they don't want to pay. They don't want to have to pay anything out of their pocket for oxygen. And as a provider, we run into that problem. We set the patient up on oxygen, and then all of a sudden, for whatever reason, their insurance company isn't paying. Well, then the patient wants to return it, or the patient keeps it and don't pay. And at that point, it becomes an ethical issue as to, can you pick up the equipment? Legally, can you pick it up? I don't know. There's a lot of questions in that. I know as DME providers out there and all the ones on the call, we know we're providing a lot of free oxygen for patients. And in some cases, they're indigent and we know we need to do that. But there are other cases where patients just refuse to pay. And that becomes a real difficult balancing act that we have to play. Payers pay one set fee per month regardless of the amount of oxygen that is needed. So if a patient requires a lot of oxygen based on higher liter flow, as far as portability and cylinders and potentially liquid oxygen, they're only going to pay one set fee. So right now, unfortunately, the equipment is geared toward the lowest cost service, that non-delivery method that I talked about, due to these substantial changes in reimbursement. And respiratory therapist visits in the home to oxygen patients are minimal, if at all. So I talked a lot about it's so important to titrate patients in the home. A lot of companies have really done away with this service, and it is a travesty to our patients. But unfortunately, if you can afford to send a therapist out once to at least get that titration, or does this revert back to potentially titrating a little bit differently in the hospital? And that's something the future will only tell. Patients are requiring higher liter flows in the home, in excess of 10. In fact, we just got an order actually this morning for a patient that was going home on 16 liters per minute. Very difficult to achieve those liter flows in the home. There is technology out there for high flow oxygen systems, and Airvo is one that I'm aware of, but there's no reimbursement. And the other existing problem is the internet and marketing direct to the patients, because what we're finding, especially with a lot of portable concentrators, is oxygen devices are being drop shipped to the patient's home. That is a problem because physicians don't understand the differences in these conserving devices. And one little scenario, we had a pulmonologist office call us a couple weeks ago and say, please, this patient went with another provider. He wanted a portable oxygen concentrator that you don't provide, and we ordered it for him. So we need you to pick up your oxygen. Well, fortunately, we have a system in place where we have a clinical care coordinator call the patient to make sure they're okay prior to us picking it up and that they got their new equipment. And the patient was very short of breath, and our care coordinator was able to determine that the device that this patient had did not even have the maximum setting that the patient was ordered. So the device only went to 4, but the patient was on a continuous flow of 8 in the home. So that is a large difference. No saturations were done on this patient, no oximetry. We ended up having to send a respiratory therapist out at our cost because we were concerned about the patient, and the patient was readmitted to the hospital. So that is an ongoing problem that exists. Unfortunately, physicians don't understand, patients don't understand. All they want is the lightest portable that lasts the longest out there. So that is something that we really need to overcome. So in summary, if we look at all of our options, we know that all of our patients are unique, and they need an oxygen delivery system that meets their needs. All oxygen delivery systems are unique and based on design and patient breathing patterns, and patients need to be assessed for the utilization of oxygen and titrated for adequate saturation at all activity levels. So with that said, I will open it up to questions. If anybody has any questions, Shauna?
That was fantastic, Kim. Thank you so much. We actually have quite a few questions. We're likely not going to get through all of these questions, but we will try our best. So there were a couple of questions that kind of centered on the same theme a little earlier in your presentation. One of the participants noted that we exercise our patients in the hospital while we're doing our testing to determine home oxygen concentration, and we exercise our patients on continuous flow, 100% oxygen from a tank, those kinds of things. Should we be exercising our patients at home or in the hospital in the same device or the same type of device, a conserving device of some sort, to get a better result, a more realistic result for the home scenario?
You know, that's a great question, and that question comes up multiple times for me when I'm doing presentations locally. But ideally, that is exactly what you would want to do. Unfortunately, there are so many DME providers, and not everybody carries the same equipment. If you can partner with 2, 3, that give you the options and to have that equipment available to you to titrate and exercise the patient, especially if you have a pulmonary lab within your facility, that is ideal. Unfortunately, a lot of times those tests are done to actually qualify the patient. Then you would have to potentially do another test with them on their home device. So, the answer is vague. Like I said, in a real ideal world, we absolutely would love to have the patient tested in the facility before they went home, but we know that can't always happen because of the multiple options and equipment availability. So then it goes back to the patient, the home care company in the home, where then that becomes a problem because a lot of companies are not sending respiratory therapists out any longer. So without the patient then going back in, so it is a vicious cycle, and I'm not really sure what the exact answer is for it.
Thanks, Kim. Another set of questions had to do with costs, and you talked quite a bit about costs and patients' costs, and the patients deciding what they're going to wear, what they're not going to wear based on what they can afford. One of the participants noted that it's not just the direct cost of obtaining the device and then paying for maintenance of the device. Am I correct in saying that patients pay for that maintenance of their concentrators?
No, that is a responsibility of the company that's providing it.
Okay, well that's good. So the patient has the device, the company who provides the device pays for that maintenance, but the patient would have to incur the cost of electricity fees to run that particular device at home. Would that be correct?
That's correct.
So in addition to the direct cost that the patient has to deal with, then there's also an increase in their electricity bill each month.
That is correct.
One last question, because we are out of time. One of the participants at the beginning of the presentation wondered if there has been a studied relationship between the 6-minute walk test and the 6-minute walk distance and the corresponding activities of daily living. Any thoughts about that?
I think that's important. I am not aware of any studies out there that exist to that respect. Whenever you get into the activities of daily living, sometimes it's not just about an exercise walk. I mean, it could be just as simple as a patient reaching up into a cupboard that has very poor upper body strength will be enough to cause the decrease in saturation. But as far as a study that correlates the two, there isn't that I'm aware of it.
Fantastic. Well, thank you so much for this presentation, and thanks to everyone for joining us today. We really appreciate your time and expertise, Kim. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation.